This program is brought to you by Emory University.
Hi, good morning, everyone. Welcome to Heart and Vascular Grand Rounds. It is my pleasure to introduce one of our own, Dr. Dan Sarescu, this morning, who's an associate professor in heart failure here at Emory, primarily at Midtown. Dr. Sarescu attended medical school in Romania, followed by internal medicine residency at Beth Israel. And then he came down to Atlanta and did vascular biology fellowship with Dr. Kathy Grinling, followed by his cardiology training here. So he's been here many years and very well known for his teaching skills. He's received many teaching awards over the years. And he was also nominated for James Steinberg Award for Outstanding Service at Midtown. He has a strong basic science interest. He was in the basic science lab area for many years, studying oxidative stress and cardiac remodeling, as well as interest in cardiometabolic risk and prevention. So he's unique in that he is a heart failure attending, sees a lot of heart failure and advanced heart failure patients every day, but also has a strong interest in preventive cardiology. So he's here today. What we've done is a little bit unique this time. This is a two-part series. So he's going to talk to us today about the basic science and some pathophysiology and mechanisms of a tale of sugar, fat, and salt. So you can kind of guess what this may be about. But then the second part is not next week, but the week after, where he'll be reviewing clinical trials related to diet. And so I'm really looking forward to this two-part series. So thank you, Dan, for being here in person, and I'll turn it over to you.
Thank you, Pooja, for your kind introduction. So may wonder why somebody who's an advanced heart failure cardiologist is interested in cardiovascular prevention. And I think just like Dr. Christian Barnard, in the immortal words of Benjamin Franklin, and I believe that an ounce of prevention is worth a pound of cure. And from this tale of sugar, fat, and salt, I'm going to address first the elephant in the room, which is the fat. And if we look at this Venn diagram where we have over 40% of people in this country being morbidly obese, as defined with a BMI over 30. About 80% of them actually are also morbid obese. That means they have prediabetes or diabetes, they are sick. However, about 20% are actually metabolic healthy obese. If you look over the lean population, defined as a BMI less than 30, but actually 60% of them also have prediabetes, diabetes. So what this suggests, and as a matter of fact, is an absolute number, the ones with the BMI less than 30 actually are more than the ones who are obese. So if you look at this, yes, obesity is a risk factor for cardiovascular disease, prediabetes, and diabetes, but really overall, the general population seem to be both populations who are exposed to a different risk type. And if we were to accumulate together, these two conditions are actually now responsible about the half of adult population, 130 million. If indeed obesity is the only problem, then really what's surprising that's in the last 5 years, the highest incidence of type 2 diabetes is actually in the lean population. I'm talking about BMI less than 25, and that would not be explained by obesity. So clear epidemic we're dealing with is more than just obesity. And one would say that both populations are exposed to similar risk factors, and sure, that risk factors could be our excessive consumption of sugar that has gone up compared to 1800s to the less than 5 pounds a year to about 90 pounds a year now. And you can see that we have a concomitant rise of both obesity and diabetes epidemic. And sure, this is association. It's not necessarily causation. That means, to quote Gary Taubes, the criminal may be present at the crime scene, but it doesn't necessarily prove that it causes that. So we're going to work on, if we were to look into the connection actually and correlation between obesity and diabetes, this is a econometric analysis that was done worldwide by Dr. Robert Lustig at the University of California in San Francisco. And there's a clear correlation here, almost linear range between obesity prevalence and incidence of diabetes. However, there are also countries here to the right side where there is 70% prevalence of obesity, but less than 5% prevalence of diabetes. And then you have this would be called metabolic healthy obese. And then you also have the other extreme to the left, Middle East countries, which actually have less than 20% are obese, but they have an incidence of diabetes that's actually higher than in US. So yes, obesity is a risk factor for diabetes, but does not really correlate with all, that doesn't explain the totalities of diabetes. And this one to the left actually are called thin outside, fat inside. And this terminology has been actually defined first by Dr. Jimmy Bell at Imperial College of London, who actually started to do MRI quantification of the fat distribution in the body. And here to the left, you see an example on an obese person who's got a lot of subcutaneous fat, but almost no liver fat. This is actually what he defined as a metabolic healthy obese. Here in the middle, you have a same kind of morbid obesity in subcutaneous fat, but then you have 24% liver fat. These are the ones who are actually going to get sick, they get diabetes, but also they tend to develop heart failure with preserved ejection fraction. And then to the right, we have the TOFI, thin outside, fat inside, almost no subcutaneous fat, and a similar liver fat as the other one. These are patients that more likely are going to develop heart failure with reduced ejection fraction. So you see, what matters is the location of the fat accumulation and not necessarily overall distribution of subcutaneous fat. As a matter of fact, you only need a pound of liver fat to accumulate in order to get sick and with diabetes. And that's, of course, not estimated by your scale. It's actually within the limits of resolution. If you gain 5 pounds of fat, then that's predictive of fatty liver too. And the visceral fat actually is driven by the stress hormones, cortisol and norepinephrine. It's not really necessarily driven by food intake. And then last but not least, you're required to actually gain about 22 pounds of subcutaneous fat in order to also cause fatty liver and diabetes. And this fact that that really liver fat is what matters has been shown by Dr. Fabrini in a study where they look at the distribution of and the impact on de novo lipogenesis and insulin resistance of the liver fat versus visceral fat accumulation. And turns out it's really the liver fat that correlated with de novo lipogenesis and also insulin resistance, and not so much the visceral fat. So between all the different fat deposits, subcutaneous fat is actually the least harmful. The most harmful is the liver fat. And then the fact that fatty liver is actually, it's a risk factor for cardiovascular disease has been recently recognized by American Heart Association. This is a study that was presented by Dr. Butler and his colleagues at the American Heart Association meeting last year, showing that the presence of non-alcoholic fatty liver disease is a major risk factors for all cardiovascular disease. And if you have actually heart failure, presence of fatty liver increase is the risk of dying from heart failure by 3.5-fold. And American Heart, as a result of that, American Heart Association actually now considers non-alcoholic fatty liver as a cardiovascular risk factor. So if we were to look at the incidence of metabolic syndrome, which precedes prediabetes and diabetes in this country, and we take at least 3 out of these 5 criteria for metabolic syndrome, actually less than 12% of US citizens are metabolic healthy. That means 88% have metabolic syndrome. This is recent analysis from 2019. So we got a major problem here, and sure, being obese is one of the criteria for metabolic syndrome. And indeed, morbid obesity per se, it's a risk factor for cancer, cardiovascular death, and Alzheimer's disease. However, if you were to look at insulin resistance, which is actually the main pathophysiology of metabolic syndrome, that is twice higher. So really the big elephant in the room that's behind obesity and epidemic of our cardiovascular disease is actually insulin resistance. And this is not new. Metabolic syndrome really has been defined by Dr. Gerald Reaven from Stanford University over 40 years ago. It used to be called Syndrome X. At one point it was called Chaos or Raven syndrome. And no matter how you define, in which country you define metabolic syndrome, everybody agrees the main mechanism is insulin resistance. If you were to look in the heart failure population, this is CHARM trial data. If you add prediabetes and diabetes, we get to 82%. If you look in heart failure with preserved ejection fraction, you look in heart failure with reduced ejection fraction, similar data. So 4 out of 5 patients with heart failure, doesn't matter the etiology, they have also prediabetes or diabetes. By the way, half of them didn't know at the beginning of the trial. And then we know that presence of diabetes confers a 2 to 3-fold higher risk of mortality from heart failure. So what about fatty liver prevalence in the general population? And where actually it's estimated we're about 45% of adults and 25% of children. And the moment you have fatty liver, your risk of developing diabetes is 3.5-fold. So there's a very tight connection between these two, fatty liver and insulin resistance and subsequent development of diabetes. So I'm gonna, for heart failure, from heart failure perspective, what I care for, if I want to prevent heart failure, then, I gotta prevent the 3 big risk factors for heart failure, which is coronary disease, diabetes, and hypertension. Actually, fatty liver and insulin resistance are strongly linked to the development of those risk factors. And I'm going to propose to you over the next 45 minutes that excessive fructose consumption in our diet, particularly sugar, is actually the main underlying mechanism, an essential factor here. Not the only one, but it's essential. So we're going to first review the drug therapies for cardiovascular prevention in cardiovascular disease, how effective we are. And then we see what's left over, what can we do about what's the residual risk. And in a seminal paper, really Dr. Robert Vogel has postulated about 20 years ago, that if we can drop the LDL cholesterol level to the level of 30, we can actually arrest coronary disease progression. And for secondary prevention, while for primary prevention, if we can drop it to 50, then we can arrest coronary disease primary prevention. These experiments have been done. 20 years later, we actually have the data now. And this is a recent meta-analysis from JAMA that is going to surprise many of you. If your LDL, indeed targeting LDL to 30 to 50, with adding PCSK9 inhibitors on top of the statin, it's effective. In particular, if your baseline LDL level is higher than 100. But actually, if we look and we treat patients with LDL less than 100, we don't seem to actually improve the outcomes. And as a matter of fact, Fourier trial, which was one of the most potent ones that we achieved, dropping the LDL to 30 to 50 milligrams per deciliter, you see the absolute MACE incidence dropped from 11.3% to 9.8%, which, if we were to look at a different way of looking at this, is that we have 87% residual risk that we have not improved, and we did improve 13%. So it's a lot of coronary disease risk that's left over if we were to just target the LDL to 30 to 50 milligrams per deciliter. By all means, doesn't mean statins don't work. It's just that only affects about 20% of our patients, even if we have that goal. Now, in contrast, if I were to look for chronic systolic heart failure therapy and I look at the same residual risk, we actually managed to drop that down to 29%. And really, for acute coronary disease, which is STEMI, is down to 14%. We've done a fabulous job there. And the question is, what can we do about the chronic coronary disease prevention to get to the same level as STEMIs? Like if we were to practice the same as STEMI, the impact that we have done on that is the reason why people go in cardiology. Is fabulous, but we're way subpar with the chronic coronary disease prevention. And I wanted to remind you that if we were to correct actually the LDL all the way down to 30 to 50, it seems that we only prevent about 16% of myocardial infarction. That doesn't mean statins don't work, and we're going to prescribe them. The question is, what are we going to do about the residual risk that's left over? And there are two main reasons that, at least with no factors that have been identified. One is 2/3 of our patients who come with a myocardial infarction have actually insulin resistance. And when it comes to insulin resistance, if we were to correct that, it's predicted that it may take care of another subsequent 42% of myocardial infarction. Insulin resistance has been considered #1 risk factor for myocardial infarction and hypertension, stroke, and cancer for actually a long time. And that's predicted as the best surrogate, a triglycerides to HDL ratio over 2.75, which seemed to be actually more predictive than just the LDL cholesterol level itself. The second reason is that coronary disease is also a chronic inflammatory disease. The proof of concept for that has been demonstrated by 3 clinical trials. CANTOS, which is use of antibody against interleukin-1 beta, that proved that it can improve mortality, although the necessary number to treat is only 100. LODOCO-2 trial, which is low-dose colchicine in patients with documented coronary disease. And last but not least, patients who have elevated high sensitivity reactive protein over 2, independent of their LDL level, benefit from rosuvastatin treatment. So if we were to target the residual risk by targeting this ratio of triglyceride to HDL, unfortunately, the results were disappointing. Whether we use fibrates on top of high-intensity statins to reduce triglycerides, whether we use niaspan or niacin or fish oil omega-3s to target triglycerides. And to our surprise also, if we try to raise the HDL even all the way up to 100 using CETP inhibitors. So why does that happen? And a subsequent analysis from accelerated trial, one of the CETP inhibitors trials, namely evacetrapib, Dr. Ritker actually showed that in about these patients, 2/3 of them actually were diabetic. They had actually a well-controlled diabetes with a target hemoglobin around 6.6. And the most important predictor for MACE outcomes, and actually 67% of all MACE, was explained by a elevated fasting insulin level of 27. Just to have an idea, normal range is less than 10. So what this suggests is triglycerides to HDL ratio, it's just a symptom of disease. What really matters is whether we are going to be able to reduce that fasting insulin level or not in terms of predicting the outcome. And the fact that hyperinsulinemia is actually a risk factor for coronary disease has been documented back in 1996. This is a New England Journal paper that showed that if your insulin level is normal, then the predictive value of elevated ApoB is only 1.8-fold. But once your insulin starts to go up higher than 12, by itself, it infers a 3-fold increased risk of coronary disease. And then together with the ApoB, the risk goes up to 10-fold. So really, elevated insulin is the sensitizer here for our ApoB and LDL cholesterol level actually to be a potent risk factor for coronary disease. And this is an example of an interesting study that actually came from our own Larry Spelman and actually Pratik Sandesara, who was working with Larry during his fellowship, that they look at actually familial heterozygous hypercholesterolemia patients from MESA study with an LDL of 190 milligrams per deciliter. And they found that a coronary calcium score of 0 predicted actually lack of coronary disease progression. But if your calcium score was way more than 0, then you have way higher risk of developing coronary disease in this patient. And what seemed to be the most predictive whether you have a calcium score of 0 was whether you had presence or absence of diabetes. So this suggests even in patients with familial hypercholesterolemia, at least heterozygous, it's diabetes adds on top of the risk of who's going to progress and who's not going to progress. So if I were to summarize all the clinical trials for drug therapies, and a different perspective looking this is looking at necessary number to treat. If we were to fix hypertension, the necessary number to treat are in the 100 range to prevent actually coronary disease, the most important being stroke prevention. Ideally, you want to have a necessary number to treat that's around 10 to say that we're really affecting, or we're actually affecting the cause of that particular condition. So we're really working only peripheral here on the hypertension. If we were to fix LDL cholesterol down to the 70, less than 70, necessary number to treat are actually closer to 39, at least for myocardial infarction. And this is secondary prevention. And if we were to add on top of that PCSK9 inhibitors to target the LDL 30-50, we drop that further to 36, but we're still far away from 10. Surprisingly, the most impactful on this seemed to be the addition of icosapentaethyl, which is the Vascepa, on top of the high-intensity statin in the REDUCE-IT trial. If you were to look at necessary number treated, it was actually all the way down for heart attacks to 3 and stroke to 5. The catch and really the major criticism of this study is actually we use as placebo mineral oil, and it's hard to know how much of the effect of this was because the mineral oil could have made it worse. If we compare this with chronic heart failure progression, we are doing much, much better. You see necessary number to treat for each individual drug is actually much closer to the 10 range, and actually combined together, it's close to about 5-1. For HFpEF, we're lagging behind. We're really close to 100 now. Hopefully, we'll have some more positive data from the high-dose GLP-1 receptor agonists, such as semaglutide, and in heart failure with preserved ejection fraction, but we are far from being as effective as heart failure with reduced ejection fraction. And if we were to target the main risk factors for all these conditions, which is insulin resistance, we have actually three drugs that really seem to be effective and shows the direction, but it's not necessarily the potency. One of them is actually ACE inhibitors, ramipril, in the HOPE trial. Not only that it helped with prevention of secondary coronary prevention, but also new onset diabetes. But most potent drug actually is metformin, with the necessary number to treat 20-1. But that's for new onset diabetes. That means as soon as you find they have type 2 diabetes, you put them on. If you start this late, 20 years later, the impact seems to be actually not so good. And if we were to actually look into effectiveness of treating the hyperglycemia as a goal of therapy for diabetic patients, we have three major clinical trials. The core trial was insulin-based, high-intensity treatment of hemoglobin 1C, advanced, and that trial. And unfortunately, all of them were neutral or negative. And as a matter of fact, trying to fix diabetes and hyperglycemia with insulin may be deleterious overall for cardiovascular prevention. There is association in a couple of meta-analyses published recently, use of insulin with twice worse cardiovascular risk on long-term and cancer. In contrast, if we treat fixed insulin resistance with metformin or actually SGLT2 inhibitors, this seems to have much more cardiorenal protection. So take-home message is here, the elephant in the room that we haven't impacted yet is actually insulin resistance. And what's insulin resistance? Why is that important at the cellular level? And Pooja probably can tell you more, where she worked for 2 years in the lab analyzing the effects of insulin and angiotensin to induce insulin resistance, smooth muscle cells. But bottom line is insulin is good and bad. It's good because it helps us utilize glucose, but it's bad also because it's growth factor. So if you have just a nice spike after each meal and goes back to normal, then we get the positive effects of using glucose metabolism. But if we have it persistent, elevated, it becomes actually a growth hormone, growth factor. And that is a major contributor to the actually fat storage, sodium and water retention, coronary disease, and growth effects that lead to coronary disease and cancer. So at least this is what we have learned in the last 30 years. And I'm gonna now try to review and convince you that in our epidemic of cardiovascular disease, excessive fructose consumption has an essential role. It actually causing this insulin resistance. And it really causes all the cardiovascular risk factors that have been associated with development of heart failure. So if I were to have an insulin resistance-centric hypothesis here, and we look over 30 years evolution, we start with metabolic syndrome, which currently 88% of people in this country have it. And that starts with hyperinsulinemia. The next stage is actually we develop insulin resistance. That's when usually we develop fatty liver. It coincides with that. And then we progress through prediabetes and diabetes. And clinical trials with using drug therapies have only addressed this issue kind of at the end of the spectrum, no matter whether we recognize it or not. It's like you got already the eviction notice, and probably that's why we have much less impact than we think. The question is, what happens at the beginning and the progression of the disease, and can we help into figuring that out? And I'm going to try to convince you that excessive fructose consumption is really part of all this disease continuum. And first, some sobering statistics. Diabetes in 1958 in US was 1%. Today, we're at 11%. It's predicted that by 2060, we're going to be at 20%. And today, most of patients who get diabetes are younger than 65. Actually, half of them are unaware. Now, if we were to compare this to 70s, less than 0.1% were 65. In other words, used to be a disease of old people, not anymore. As a matter of fact, it's moving to younger and younger population. Currently, we have quite a few children who have type 2 diabetes, but the most worrisome part is that it's predicted that incidence of type 2 diabetes in children will go up by 700%. And why does that matter? Well, it matters is the cumulative exposure to risk factors. What we know matters for cardiovascular disease. So the younger you're going to start this, the longer you're going to be with this cardiovascular risk exposure. Question is, what causes this into kids? And I'm going to try to show you that really it's fatty liver and insulin resistance, which coincides with this type 2 diabetes in children. And it's caused by excessive sugar and fructose consumption. And when I say fructose, and most of us probably know, but sugar is really glucose and fructose. And it's not the glucose that's the enemy, it's actually the fructose. And I'm going to show you specific biochemical pathways how fructose does that. But really the first one to actually bring this in front for that fructose can be the villain is Dr. Robert Lustig, who is a pediatric endocrinologist at the University of California in San Francisco. He had a seminal lecture that he posted on YouTube, Sugar, the Bitter Truth, where he realized that prior to 1990, children did not have either fatty liver or diabetes type 2. These are two conditions that started to appear after 1990s. And if prior to 1990 you had fatty liver, you were an alcoholic. But children don't drink alcohol. So how come they develop this? And he found that actually biochemical pathways of metabolizing fructose in the liver are identical with the biochemical pathway metabolizing the alcohol. So he says, well, guess what? Sugar is the alcohol for the kids. And just so you know, fructose is not really, and sugar is not the only villain here. There are three other poisons that we eat every day that have been incriminated into this. One is the trans fats, oxidized omega-6. Second is alcohol. And the third is actually excessive consumption of branched chain amino acids, typical protein bars, protein supplements. And we're going to talk about that in part 2 of this lecture. But bottom line is, let's see what's the proof that sugar causes this. Of course, we increased dramatically sugar consumption in this country, currently at about 90 pounds a year or 90 grams a day. And if you look at Medicare costs that overlap with the introduction of high fructose corn syrup, they started to go dramatically up after that. And we're currently close to about $1 trillion for that. And then most recently, Dr. who is the head of nutrition epidemiology at Harvard, has demonstrated that there is a strong link between excessive sugar consumption and 3 to 4-fold increased risk of cardiovascular death. So we have association, but is it possible, and how does fructose do that? And Dr. Richard Johnson from University of Colorado, who is a nephrologist, actually has done basic science studies both in mice and humans that's proven actually the whole metabolic pathway, how fructose does this. And it turns out we have an evolutionarily conserved pathway that makes that particularly sensitive to fructose. The purpose of that was back then when we didn't have much to eat, we were eating a lot of fructose from fruits and honey right before the winter, so we can fatten up, so we can survive over the long winters with less food. So fructose triggers basically a starvation and nutrient deprivation signal in our liver that converts then everything into fat deposition, and including insulin resistance. And the purpose is to preserve glucose for the brain, but also preserve water. Camels use this in their mechanism. They actually store water as fat, and that's in a vasopressin dependent mechanism. Also, it turns out that rat moles that live only below Earth in condition of very severe hypoxia, they use fructose to change their metabolism to actually shut down their mitochondria, so they can survive in low oxygen conditions. So we have an evolutionary conserved pathway, but how does exactly this work? And if we look at sugar, sugar has glucose and fructose. Glucose is metabolized very different from fructose. If we ingest sugar, most of the glucose will actually either be stored in glycogen or is just let pass free back in the plasma, so all tissues can feed. In contrast to that, fructose, much like alcohol, is metabolized towards fat production. There are three compounds that are produced. One is acetyl-CoA that is going to be shifted towards actually fatty acid formation, triglyceride formation, and fat deposition, first in the liver and eventually in the VLDL that's excreted. The second compound is methyl glyoxal, which is catabolic product of fructolysis. We're going to talk about that, the consequence of that. And the third compound is production of uric acid. All these three elements actually have been incriminated in development and progression of fatty liver and insulin resistance. And last but not least, fructose actually induces a energy deprivation. Sorry, it basically depletes hepatic cells from ATP and causes cellular starvation by shutting down the mitochondria. So before we go further, the question is, okay, what is the safe amount of fructose that it's good for everybody? And this study actually was done in Dr. Zhang in a paper that was published in Cell Metabolism, showed that anything that's less than total 12 grams fructose intake a day is actually metabolized by the gut. Our gut is there to protect us actually from excessive fructose consumption. But if we ingest more than 12 grams, so that'll be, if you multiply by 2, that'll be equivalent of about 24 grams of sugar, equivalent to about 6 teaspoons. Then everything else starts to be absorbed in the liver. Liver takes up about 90% of that, and 10% goes into the circulation. So gut is designed us to protect from fructose. And based on that study, actually, why American Heart Association guidelines recommends that our daily sugar intake should be less than 6 teaspoons of sugar a day. The current actually data shows that we're really eating 3 to 4 times higher than that. It's equivalent now about 90 grams a day across the population. So when it comes to fructose, the toxicity is dose dependent. The dose determined the poison, as Paracelsus said back then in 1537. So how does fructose really make us sick? I'm going to present you 6 mechanisms. One is it stimulates, it makes us eat, makes us hungry. This is how we regulate food intake. There are 3 brain centers: the homeostatic center in the hypothalamus, which receives strong signals from the executive center, which is the prefrontal cortex, and the pleasure center, which is our reward system. If we like something, we're going to eat more. And if you were to give glucose and fructose, which is sugar, to somebody who is actually metabolic healthy and insulin sensitive, there is not much impact there. We actually don't get much extra stimulation. Glucose, if there's anything, component of it will make us want to eat more, but fructose actually will make us eat less if you're insulin sensitive and lean. Now, in contrast, if you're obese or you're insulin resistant, you seem to have exactly opposite effect. You actually get addicted to it. We stimulate our pleasure center and homeostatic center and actually inhibit the prefrontal cortex. Basically, we lose our mind and we don't realize we eat and we just want to eat more. It actually prevents us from having satiety and fullness. So you can have actually a huge binge on sugar and you're getting hungrier and you don't realize in one coffee, you could have ingested 2,000 calories a day, which is already what you will have to take for the whole day, and then you're still hungry. So bottom line is fructose stimulates our reward mechanism, particularly if we have insulin resistance, and actually makes us eat more. It changes our biochemistry, which then changes our behavior. So when it comes to after you already had that sweet sugar in your mouth, I doubt there is any, your weight is a matter of your free will. From that moment, actually, it's a matter of fructose taking over your brain and going by the path of pleasure, which is, I agree with that. So the classic dogma of how we actually get obese and sick more is that we have a increased calorie intake and reduced exercise that causes obesity. Then obesity is going to cause us insulin resistance and fatty liver. And really, data from the last 20 years actually have refuted that hypothesis. Is the alternative hypothesis actually, this seems to be correct, is fructose or alcohol or some other compounds like that, independent of their calories, actually cause increased intake, fatty liver, and diabetes and insulin resistance. And that has nothing to do with the calorie content of the drug. Now, the second mechanism how fructose actually can cause cardiovascular disease and particularly dyslipidemia is that both the glucose causes advanced glycation end products. That's why we measure the hemoglobin 1C. But fructose seems to accelerate that reaction about 7-fold faster. And especially its byproduct, which is methyl glyoxal, which is the element of fructolysis, catabolic product of the fructose I was telling you about. And why is that important? It's important because the first stage in developing small dense LDL, the oxidized LDL, the small particles that actually cause atherosclerosis, is glycation of the LDL, and particularly the apolipoprotein B. That is a non-enzymatic binding of either glucose or fructose to lysine residues actually in the ApoB, and it's the first, and it oxidizes, and when it does that, actually releases molecules of hydrogen peroxide. The second stage will be the actual oxidation of the cholesterol, but that's very important. And there's a cumulative impact on age formation from chronic excessive fructose exposure to this. Now, the third mechanism that I would like to talk about is that methyl glyoxal not only is an age product, but also it turns out that it binds irreversible to the catalytic subunit of AMP kinase. So why is that important? Well, AMP kinase is our energy sensor for the cell. So if your AMP kinase works, then you're actually going to burn your glucose and your fat in the cell, but also you're going to regenerate your mitochondria. If your AMP kinase doesn't work, you do the opposite. Your liver cell is going to make glucose, is going to make fat, and it's going to make cholesterol. And that's anything that we ever wanted to do in cardiovascular prevention. If you activate AMP kinase, that's protective. If you inhibit it, that's deleterious. So that's number one. The second other part, so what are things that stimulate AMP kinase? So everything we knew is healthy for you. Fasting, exercise, not prolonged fasting, but fasting, exercise. Two drugs that we know works in cardiovascular prevention, metformin and SGLT2 inhibitors. And on contrast to that, we have, if we were to able to do that, then actually AMP kinase tell us to burn our stores. And if you have excessive fructose consumption through the methyl glyoxal, which is a irreversible inhibitor of AMP kinase, another job of AMP kinase is actually to keep in check the mTOR, which actually drives proliferation in our cells. And if you remember, mTOR, it's a target of rapamycin. We use that for immunosuppression of T cells. As a matter of fact, there are now studies ongoing that is looking at preventing aging and prolonging lifespan in humans. In other words, you want your mTOR to be minimal, mildly activated 2 or 3 hours a day. You don't want to have it constant activated. That's actually related to autoimmune conditions, cancer, and diabetes. So that's one of the job of AMP kinase that actually suppressed by methyl glyoxal. And this is how we change our cellular phenotype from adult glucose and fatty burning phenotype to a growing and storing and inflammatory phenotype. And that happens not just in the liver, it happens in the muscles, it happens in the brain, and that's extremely important. Now, the second villain that fructose produces, other than methyl glyoxal, is actually uric acid, which causes oxidative stress and is seen to be incriminated also in the development of fatty liver and cardiovascular disease. Now, there is yet another mechanism that fructose actually is able to stop our fatty acid burning, and that's because it blocks two more enzymes, ACADL and CPT1, which are essential for fatty acid transport in the mitochondria. So basically, if you eat glucose concomitant fructose, while glucose otherwise will go into the mitochondria to be burned and also stimulates the fatty acid burning, the fructose actually will block all that and drives all the metabolism towards storage as opposed to burning. And as Dr. Robert Lustig said, a calorie is not a calorie. If it cannot be burned, it will be stored. Now, this is a complex slide. I'm not going in this. The only point I'm trying to make, other than already know, is that also fructose, it's by causing mitochondrial dysfunction, actually, and acetyl-CoA increase drives the insulin resistance by increasing the diacylglycerol. And it's a pathway that actually has been shown by Dr. Jerry Schulman at Yale, where your excessive acetyl-CoA leads to production of triglycerides, particularly diacylglycerols, which go in the plasma membrane, activates protein kinase C theta, and that's the one who actually phosphorylates the IRS receptor, makes the insulin receptor becoming insensitive to insulin. So, while all this is done, what is the evidence in human this actually happens? So this is a study that exposed patients, actually people, to 2 weeks worth of high fructose corn syrup versus fructose, and glucose was used here as a control. And you see that those were, then after 2 weeks, they measured their LDL level goes up, ApoB level goes up. That's within 2 weeks, and the triglycerides. Now, the same group 10 years later actually did a more extensive and longer exposure to fructose, high fructose corn syrup. And this is a 12 weeks exposure. And look at actually liver fat and 12 weeks exposure, dose-dependent manner, starting with 10% fructose in the diet, going all the way up to 25%. It's shown that the liver increases the liver fat and de novo lipogenesis, causes glucose intolerance, elevated insulin and lactic acid production in a dose-dependent manner. So this pretty much shows you that actually excessive fructose intake in humans over a 12 weeks period reproduces everything we know is wrong from metabolic syndrome, fatty liver, and insulin resistance. And you'll think, well, that's 25% fructose in the calories. Who does that? Well, here's a range of the sugar content for classic sugary coffees at various places, and here namely is Dunkin' Donuts and Starbucks. If you go all the way to the left, you get all the way up to equivalent of 14 donuts of sugar. You actually, to reach 25% of fructose, you just need one of the middle ranges of these coffees a day. This is actually nothing compared to what our teenagers consume every day. So yes, it's very doable. And they also did a more extensive analysis of the lipoprotein particles in this. And this is a complicated slide. You just need to focus on these higher numbers of triglyceride-rich particles, what is P5, 6, and 7. Why? Those are IDLs and VLDLs that contribute to the small dense LDL formation, the 20% small dense LDL that actually is pro-atherogenic. And this goes dramatically up, actually, both fasting and postprandial after 12 weeks of exposure of this high fructose corn syrup. And this is the LDL version of it when you look at the small dense particles that also goes dramatically down. So, and what's most importantly is that ApoC3, apolipoprotein C3 goes up, and you say, why am I mentioning ApoC3? What does that do? Here's what it does. It's actually in charge of those 67% of our MACE components in forming the small dense LDL and oxidized LDL. So if you look at all LDL is not bad. Actually, 80% of them, the large LDL particle type A, is fine. It's used by our body to provide cholesterol and triglycerides. The issue is the 20% that gets small dense LDL and oxidized. That's what causes atherosclerosis. And if we were to look at where is that coming from, actually 67% comes from the ApoC3 containing triglyceride-rich particles, basically IDL and VLDL, particularly typical for diabetic dyslipidemia. So, and it turns out that fructose is a very potent stimulus of this ApoC3 induction, and insulin actually inhibits it. So actually we have, if our liver is insulin sensitive, that prevents that. But once you get fatty liver and you become insulin resistant, then fructose is a strong driver of this ApoC3 incorporation into triglyceride-rich particles. And ApoC3 is very different because if you replace ApoE, which actually stimulates lipoprotein lipase, ApoC3 does the opposite, inhibits the lipoprotein lipase. That means this particle will keep traveling in the circulation, but there won't be much of a triglyceride uptake from the tissues. And the only fate of these particles is actually to eventually be converted to either small dense LDL or small dense HDL. They can be only picked up by scavenger receptor on the macrophages. And these are the ones who actually contribute to coronary disease. More recently, Dr. Furtado at Harvard, in an elegant study, has shown that actually not HDL is healthy. This small dense HDL that contains the replaced ApoC3 instead of ApoE is the one that actually is as deleterious as the small dense LDL. So ApoC3 is really a potent marker when you start to have them in this triglyceride-rich particle production in the body. So I showed you evidence that we have a evolutionary conserved pathway for fructose to change the biochemistry towards diabetes. We have a strong association between sugar and type 2 diabetes and cardiovascular disease, also correlation. I'm going to show you some data actually for causality, okay? Because association is not causation. So this is a study that actually was done by Dr. Robert Lustig and his colleagues from the University of California in San Francisco. And he took 40 teenager kids who have morbid obesity, pre-diabetes, and dyslipidemia and fatty liver. And then he did an isocaloric substitution experiment where he reduced sugar consumption from 14% of calories in the diet to 4%, which means they replaced sugar with glucose, with starches. It didn't give them necessary healthy food. All it did is replace the fructose component with the glucose component. And this was isocaloric. That means they ate the same amount of calories. They actually made absolutely sure their weight stays stable. And this was a 9 days experiment. And these are the results. Fatty liver in the fat went down by 20% according to the MRI scans. De novo lipogenesis also went down by 15%. Blood pressure went down, LDL cholesterol went down, fasting triglyceride went down for almost 50%. In a similar way, insulin resistance and actually fasting insulin went down by 50% to actually they were able to reverse prediabetes to normal insulin levels. And that's only 5 days of removing sugar in the diet. And this study actually has been replicated by Dr. Voss Marlene from actually Emory University, Children's Hospital in Atlanta, but in collaboration with other groups from Berkeley and University of California and San Diego. It's not new. And when Dr. Lustig and his colleagues further did a lipoprotein analysis here, when we want to look at the small dense LDL and HDL in yellow and red, okay, it turns out that also 9 days reducing the fructose to 4%, reduce the ApoC3, triglyceride HDH ratio, small LDL and small HDL particle. So in conclusion, really removing fructose from 14% to 14% daily calorie intake, independent of weight, improves our lipid profile, improves insulin resistance, but also the main mechanism appears to be by improving fatty liver. Dr. Lustig also published an economic analysis of how relevant is this to the epidemiologic level. And he found that basically look into what is the impact of sugar consumption into various countries compared to incidence of diabetes. So he found that only changes in sugar availability correlated with diabetes prevalence. If you ate extra 150 calories a day, that led to an extra risk of diabetes prevalence just by 0.1%. But if those 150 calories a day were from a can of soda, that preceded the onset of diabetes by 11-fold, which is a big difference. And he actually went to estimate that about 25% of diabetes worldwide is explained by sugar. And this is controlling for other food types, overweight, total calories, obesity, urbanization, and income. Basically, I also showed you evidence that actually reducing fructose in our diet improves our chronic metabolic conditions. Increasing sugar in our from soda increases by 11-fold our risk of cardiovascular disease. There are countries, by the way, like New Zealand, who actually they dropped that sugar intake and they showed that diabetes went down there. So it goes both ways. And just so you know, this is considered actually a Bradford-Hill criteria for causality. The same criteria were used actually to prove that smoking causes lung cancer. The last story that I'm going to tell you, yes, the last story that I'm going to tell you, that's exactly what I need, is actually the role of fructose in hypertension in humans. And there are actually 3 mechanisms how does that. One is through the uric acid production, which is actually inhibits the endothelial nitric oxide synthase and causes oxidative stress. The second, I'm going to show you a study that's done in rats, where these rats were exposed for 16 weeks to high fructose in their diet. And what was interesting is that, of course, they ate more, they got more obese, but they also seem to, and they drink more water, but it turns out they retain water when they measure their urinary volume. And it causes fatty liver, as shown by elevated ALT, causes the typical diabetic dyslipidemia that we see in humans. But what's fascinating, also their plasma renin, was going up. So then they get hypertension, and they also get glucose intolerance over a 16 weeks period. And then when they look at renin-angiotensin expression in the kidney, they found there was actually tremendous upregulation of renin, angiotensin, and in juxtaglomerulus apparatus of the kidney. So then they said, okay, is this really mediated through the renin-angiotensin system? They actually gave renin inhibitor that actually turns out not only that prevented hypertension, preventing the increase in insulin, dyslipidemia, but also resolved the hypertension. So this study, in summary, showed that really fructose indirectly, by increasing renin-angiotensin activation in the kidney or plasma, actually contribute to long-term hypertension. And sure, this is rats, but what about humans? And here is a meta-analysis that was actually published a month ago. This is a Cochrane review, analysis that showed that actually excessive sugar consumption from soda is associated with 6 to 8 millimeters mercury increase in systolic and diastolic blood pressure. But if the fructose comes from fruits, not from sodas and sugary beverages, actually there is opposite. It's a reduction by 6 to 8 millimeters mercury. And we kind of know that from the DASH diet. This is the whole basis of that diet, having 5 fruits and vegetable servings a day. And basically it proves that actually fructose, there's a strong connection between fructose and hypertension in humans, not only in rats. The third mechanism, actually, that fructose, and maybe the most important one, actually can cause us hypertension or contribute to that, is it turns out that fructose is absorbed both at the gut and the kidney level by using the glucose transporters, and 2 and 5. But at the kidney level and the gut, it also requires sodium hydrogen exchanger. In other words, you cannot absorb fructose without absorbing sodium. So fructose consumption drives sodium retention. And that's very important because this sodium hydrogen exchanger is present also not just in the kidney, but also in the heart and in the gut. Is actually been incriminated to be activated by insulin and pioglitazone. This is actually the mechanism of how we have congestion and worse congestive heart failure with pioglitazone. And guess what? Is blocked by SGLT2 inhibitors. Now, this is speculative what I'm saying, but I believe that actually the main mechanism how SGLT2 inhibitors actually provide cardiorenal protection is actually not only because they block the sodium and glucose transporter 2, but also because they actually block the sodium hydrogen exchanger. So if we were to sum this up, fructose contributes to human hypertension, not only by activating a sodium hydrogen exchanger and sodium retention, but also by renin-angiotensin activation long-term, but also it turns out it increases also the sympathetic output. It pretty much reproduces every neurohormone activation we know is deleterious in cardiovascular disease formation and human heart failure. And if I were to look back, I'll say, okay, fructose causing sodium retention and water retention, and is possible that contributes to congestion in our patients with chronic congestive heart failure, directly or indirectly through the neurohormone activation. And for about 20 years, we've been advising my patients to reduce their sodium consumption to avoid hospitalization for heart failure. But I think probably we ought to think about, that begs the question, whether we actually should focus more on the sugar, because it turns out if you have a low sugar intake, even if you have a little more salt intake, it's not going to stay in the body, it's going to go down. It's the fructose that makes you retain sodium. And this is the hypothesis that came out of the studies. So in summary, basically, insulin is good and bad. It's good if we can get the insulin up and down in physiologic states. It's bad if we actually have it high elevated and never goes back to baseline. Why? Because we activate the growth inflammatory component of the insulin effect. And fructose is behind actually insulin resistance and angiotensin A2 activation, and changes this balance towards growth phenotype. also by inhibiting AMP kinase and activating mTOR. This is a summary of everything I just stated. I'm not going to go over. I'll be happy to take any questions at this point.
Great. Thank you so much, Dr. Sarescu. That was an amazing lecture. I think you saved us hours and hours and hours of literature review and time by summarizing all the key points and mechanisms related to the fructose story. I'm going to open it up for questions. I can start off with one. So, you know, for diabetics or just and even non-diabetics, if you were to eat a lot of fruit, just oranges, grapes, etc., what are your thoughts on that as opposed to the, you know, we've always said processed foods and sugar, but what about just regular sugar in fruits?
So at least in human hypertension, you saw that actually fruit intake is actually associated with actually lowering your cardiovascular risk. So fructose in fruits is bound to fiber. So Mother Nature designed the poison that comes with the antidote. The antidote is the fiber. That binds the fructose, so it actually makes it less bioavailable to be absorbed from the gut. Basically, if you eat the fruits, you're going to be full, and you're going to have no problem with metabolizing the fructose because very little is going to get into the liver. Of course, there are fruits with high fructose, low fiber ratio, like pineapple, and those are a little more dangerous. That if you eat a lot of those, you can probably get to trouble too. But most of the time, eating fruit as it is not a problem. The problem is this: once you start to mechanically disrupt the fruit by doing a smoothie or juicing it, because you kill the fiber and all you do is just concentrate the fructose and then becomes 100% bioavailable. So I'm all for eating the fruits, like Dr. Lustig said. I do not recommend juicing or smoothing it.
Thank you, Dr. Smith.
Dan, I think this whole subject is so important and so difficult. You know, the obesity epidemic, as you point out, is an epidemic of inflammation. We know that patients who have HFpEF and are obese, they represent a particular phenotype. And it's a question is how do we really impact all of this on a society level? Dr. Lustig, who you point out, I've listened to one of the talks that you sent to me. He's actually getting a law degree so that he can defend himself against some of these companies that are coming after him. So much of this is tied into our economy in part, but ultimately it's hurting our population. My brother, who trained in cardiology here and is a cardiologist in Tallahassee, he's part of a Society for Lifestyle Medicine, and I've been learning a lot from David, from what he's been learning. I would encourage all of our cardiologists to look into some of these lifestyle areas and how we might impact patients. But from your standpoint, how do you think we can influence to a large extent what's going on among our population? Obviously, you're doing it one patient at a time and educating us, but what are your thoughts around that?
Most of the second part of the lecture is about that. And I think number one, as educators, we need to keep it simple. And that's why I prefer today to just talk about one element and one component. I think we have complicated too much these dietary approaches because we said, well, it's this and that and that and that. But actually, if we were to sum this up, and right now, I can tell you, I got down the dietary advice for the patient to less than 5 minutes. Basically, I showed them a dish of Mediterranean diet, and I said, can you eat like that? And I say, what's the difference between this and that? The other one, I showed them examples of a breakfast, lunch, or dinner coming from ultra-processed food. So the next hour lecture will be all about what's in the ultra-processed food and what are the other three villains that cause that. And it turns out, quoting Dr. Lustig again, actually, we have actually excellent clinical trials. I'm talking about prospecting randomized Mediterranean diet versus keto diet versus, DASH kind of diet, where as long as this food is unprocessed, any diet works. So if we could start and convince our patient to wean themselves off from ultra-processed food and actually cook at home, and then they don't have to worry about, oh, what's the sugar, what's the carbs, what's the sugar. Doesn't mean they will never eat sugar again. But I tell them, look, you can eat anything sweet you want, but no, it's a dessert, which means cut it down to once a week. Make it as a treat. Doesn't mean you'll never eat that again. And of course, the same goes with alcohol. So if we can simplify the message, what are the 2 or 3 villains that are most important? And then they're all packed up into the actual, what we mean by ultra-processed food, and make sure, and I'm going to show you evidence for that, by the way, and then make sure we have a simple message for patient. That's at our level. Second, in terms of impacting somebody who's 300, 400 pounds, how are you going to help them? It is very likely that actually having to kickstart with an high dose, semaglutide or Ozempic-like agent for them to start losing weight, because that's the first step at actually achieving, treating the metabolic dysfunction will be important. But I still think if they don't change their diet to eat a healthy, real diet as opposed to ultra-processed food, that's not gonna make a major impact. And in terms of policies and how to change that, the reason why I put this together is because healthcare workers are the number 2 workers actually by impact in this country. We are the fastest growing population. We're close to 20 million right now. So I thought before I try to treat the 130 million, if we can target those 20 millions, at least we are aware where the main enemy comes from, and then we can spread the word, that can make a major impact. So if all of us, we keep talking to each other and we keep telling this, I think that can make an impact. Now, it won't be in a year or 2, but it will be in 30 years for sure. And that 30 years can start now, that can make a big difference. I mean, smoking in public places, even using the belt, took 30 years to get there, and but like again, Dr. Lustig says, what it took is people who were opposing, they died, kids grew up and you taught them, and then they voted, and then the laws were changed. But we can start with what we can do. Yeah.
Dan, this is Abi. Can you hear me?
Yes.
Yeah, that was a fantastic lecture where, only someone like you can kind of synthesize the basic science and distill it down. So thank you for doing that. In listening to your lecture, one thing that strikes me is it's not particularly easy or accessible to measure liver fat or insulin resistance. Do you see, in order for this to sort of really have traction, people, they need to see it for themselves, like how their liver is laden with fat or how they're suffering from insulin resistance, and it's not easy to measure. So do you see, can you talk about where this is headed in terms of making it easier? Is there technology or something that's available to make it easier to measure liver fat, short of getting MRIs? And
yeah, we're not gonna ever get MRI on every patient to see their metabolic risk profile. You're right. We do have surrogate markers that actually, I would say, we can identify probably easily 80% of that. And again, Dr. Lustig is the one we'll have to change. So first of all, what really matters is the insulin level. Okay. Of course, our American Diabetes Association guidelines tells you don't measure insulin level. But if I were to say I want cardiovascular risk factor determination and prevention, we got to measure the fasting insulin levels. Okay. If insulin level is more than 10, unless you drop that down, nothing you do is going to change the outcome. So that's number one. We can start by measuring insulin level. Of course, sometimes it's paid, sometimes not paid. It's actually $10 a test. Medicare doesn't cover for it, but you can start to clarify for yourself and with your patients. I tell them, look, it's up to you. If you want, I can show you, part of what's going on with you. I think you have problems with prediabetes is because I can measure your insulin levels, see what that is, and that convinces them because people believes in numbers. So that's one thing we can do. The second is the best actually surrogate marker from the lipid profile for elevated insulin is actually triglycerides to HDL ratio. That's another marker of actually fatty liver. It's a biochemical marker. So that ratio, actually, you don't have to have triglycerides being higher than 150 or the HDL to be lower than 40. If you do the ratio, if it's higher than 2, it's abnormal. That tells you actually early fatty liver disease. All right. Now, if we want to say coronary disease, then we can look into that factor being 5 or 3, but the disease starts much earlier than that. The third part, you can measure ALT. ALT, if it's higher than 25, that's predictive of fatty liver. And last but not least, you'll see when you send for a liver sonogram, actually many of those patients will come back, oh, I got fatty liver, but that's usually a little more, advanced. So there are actually ways. I highly recommend, to answer your question, Dr. Lussing has done a much better job. Read his book, Metabolic. That's actually really a lot of this, what I put in this lecture, it's extracted from there. And he had put all the science together. And that's a book actually written for doctors, that it's an amazing update of real science behind all this. I don't know if that answers your question, but we have ways how to look into that. We just have to look.
Yeah, that's great. Thank you, Dan.
Any other questions or comments?
Right.
Okay, great. Thank you so much, Dr. Sarescu, and I'll see you again in a couple of weeks. Thanks again.
Thank you, Pooja.
The preceding program is copyrighted by Emory University.